Our next topic is going to be women's bone and joint health. And as I mentioned, we have two folks that are going to be speaking today. The first one is Dr. Sandeep Gidvani. Dr. Gidvani went to medical school at New York Medical College. He then did his residency at Penn State at Hershey Medical Center and his fellowship at UCLA. Our other speaker is Ann Pfeifer. And Ann works here at the hospital, and she is a physical therapist. She has her master's from Duke University, and she specializes in orthopedic and neurological care, including aquatic therapy, Pilates, and yoga. She has a special interest in training on osteoporosis management, and she actually teaches a class here on osteoporosis here at El Camino Hospital, Los Gatos. So I just shared with you about Dr. Gidvani, and the only thing I did not share with you is in regards to his comprehensive fellowship training. He's actually a spine surgeon that specializes in complex spinal pathology, including cervical, thoracic, and lumbar stenosis, instability. What is that word? Okay, he's going to talk about that. That's one of the ones I know: scoliosis, deformity, myopathy, degenerative. Anyway, he'll go over all of these different things. And here we'll get started. So again, we'll have 20 minutes, then 5 minutes for Q&A, and then both Dr. Gidvani and Ann will be in the back to answer any questions that you have.
Okay, well, can everybody hear me okay? Okay, good morning. I just wanted to thank everybody and El Camino for giving me the opportunity to speak about osteoporosis and some spine health and spine disease. You know, I'm an orthopedic spine surgeon, and my specialty is spine surgery, but as part of anybody who's in orthopedics, you've had extensive training in bone health and bone biology, how things develop and how things deteriorate. So osteoporosis is a very important diagnosis that needs to be on everybody's radar whenever you're treating any portion of orthopedic health. So osteoporosis is a widespread disease, and you can see from the picture there, the picture on the left shows, or your left, shows a normal looking bone structure with some of the matrix taken away, but you can see that there's a very highly populated structure such that there's a lot of bone interarticulating with itself. On the right, you see a picture of somebody with osteoporosis. Obviously, the marrow has been taken out, but you can see that the structure is depleted significantly of the trabecular bone. And so that in itself causes a lot of weakness in the structure of the bone overall. On the right, there's a slide that's a little bit washed out, but what, you know, in bone health, it's basically as you live through your life, you have a process where bone is constantly being formed, where it's being laid down, and then also it's being broken down. And this is called bone remodeling. So anytime you have a fracture, even as simple as breaking your wrist when you're a child, your bone's ability to form new bone is ramped up. So you begin to lay down new bone, and it forms a hard callus. So that's why when kids have healing of a fracture, you feel a big lump where the fracture was healed. Over time, your body remodels it, and the lump goes down, and it forms new mature bone, and that process is completed by the osteoclast. So there's two bone cells that are of major importance, the osteoblast and the osteoclast. The blast is blastic, or forms new bone, and the clast is clastic, or breaks down bone. And so osteoporosis is basically an imbalance between these two cells. The osteoclast now has more power and is breaking down more bone at a faster rate than the osteoblast can make it. Okay, and that's why you get the structure over there on the right. So at the bottom, I say there that the peak bone mineral density, that's what BMD is at age 30, and then from there on out, you continue to lose 0.2% per year. Okay, so some basic statistics for you. So over 200 million people in the world suffer from this disease, and approximately 30% of all postmenopausal women have osteoporosis in both the United States and Europe. At least 40% of these women and 15 to 30% of men will sustain one or more fragility fractures in their remaining lifetime, and we'll talk about what those fragility fractures are. And if you've had one fracture, one of these fragility fractures, your risk for another, or risk for osteoporosis, goes up 86%. Okay, so see, these are some of the risk factors that are listed here, and there's a long list, and I'll go through the major ones. So there are some race associations. Females are at greater risk than males, and that's why I'm here giving this talk today. Postmenopausal, you're at increased risk. Smoking or alcohol abuse, a lack of exercise, being sedentary for most of your daily routine, poor calcium intake. There's certain medications that if you take them or take them on a chronic basis, your risk increases. So steroids, Wellbutrin, often used to treat depression and sometimes to help quit smoking. Lasix is used as a diuretic. If you've had chemotherapy with the drug methotrexate, or if you take or have taken anticonvulsants. Those patients who've had a gastric bypass also are at increased risk because of the way that your body absorbs calcium. Diabetes, and anybody who has had a transplant of any of those organs listed there, and that's usually because when you have a transplant, you have to suppress your immune system for a prolonged period of time, and the way that's done is with steroids. So, and I mentioned that was a risk factor to begin with. Anorexia, celiac disease, and neuromuscular disorders because of the immobility that results from it. So here you see a chart, and it shows both women and men, and on the left side you see the rate of fractures per year, and on the bottom you see the increasing amount of age, and you can see that as you go up in age for both men and women, the amount of fractures increases. The green is a vertebral compression fracture, the blue is a hip fracture, and the magenta color is a wrist fracture. And you can see, if you compare women to men, that the rate is much, much higher when you look at the per 10,000 per year. So these are some of the common fractures that people sustain. Usually this is sustained from a ground level fall or standing height. Sometimes you'll fall onto your buttocks, sometimes you'll fall straight forward, but you know, if you extend your wrist out in front of you and try to brace yourself, you can fracture your wrist. Normally your bone health should be of enough quality such that it should be able to sustain that fall and not fracture, so that's why this is called a fragility fracture. Hip fractures, which are very common, we see them all the time. They've become a national health measure. Hospitals and practices are out to sort of establish protocols to be able to treat these in appropriate amounts of time because they have other implications in terms of your overall health. Here on the right, you see what's called a proximal humerus fracture up in your arm. And then down here on the bottom, because it kind of washes out there on the x-ray, you can see a compression fracture, basically a loss of height of the vertebral body when you look at the bone from the side. So how do we make this diagnosis? It's very important to know if you have it, correct? Because if you have it, then you need to seek treatment for it. So one is a fracture. I mentioned to you that if you do sustain one of these ground level falls and have a fracture from it, then that should be a red flag. It should go up whether the orthopedist is treating you, whether it's the emergency room physician, or your primary care physician that's seeing you. Each of those physicians should be entertaining the next step, which is to work you up for an underlying problem such as osteopenia or osteoporosis. Okay, that's often done with a metabolic bone panel, so a series of blood tests that are taken, including your thyroid levels and your body's ability to produce vitamin D. In men, they look at testosterone. That's been found to be a significant source of osteoporosis. And what are the preventative things that can be done, or how do we seek to find out what level of osteoporosis you have? And that's what we use a DEXA scan for. DEXA stands for Dual Energy X-ray Absorptiometry, and basically what they do is evaluate both your hip and your spine, and you get two different scores. So I'll show you what that is here. So a DEXA scan looks at the main region in the femoral neck where the bone density should be highest, and also looks at the vertebral bodies. What it seeks to evaluate is the bone density. So these little charts that you see here indicate bone density, and then on the bottom is the age, and these are sort of normal graphs, and then they plot where you fall on there. Okay, and basically what they do is they compare you to your bone density to people of the same age and to people around the age of 30 who are considered normal, healthy females or males. So who should get this scan? When should you get it? So screening is recommended by the National Osteoporosis Foundation for all women over age 65. However, you're under 65 and you've had the following, then you should also be screened. So like we talked about, a fracture, as we described, a loss of height overall in terms of how you stand, secondary to a fracture within your spine. If you've taken steroids for an extended period of time, 3 months or greater. If you are just a smaller overall stature, so your body mass index is less than 19 or your weight is less than 127 pounds. If you have a family history or immediate family member that's been diagnosed with osteoporosis and is being treated for it, then you should have a DEXA scan. This one is sort of iffy. Early menopause. If you go into menopause at age less than 45, you may consider at least have this discussion with your physician, your primary care physician. If you're between 45 and 65, I put this line in here, and you're premenopausal, a bone scan is not recommended unless you've had one of these other risk factors mentioned. And talk with your doctor if you have other associated disorders that are commonly tied to osteoporosis, such as rheumatoid arthritis or celiac disease. So I talked about the T and Z score results. The T score compares your bone density to a healthy 30-year-old of the same sex. The Z score compares that to an average person's bone mineral density with the same age and same sex. So a T score of less than negative 2.5 means you have osteoporosis. If you're between -1 to -2.5, you have osteopenia, meaning your bone is starting to thin. The process where the osteoclast is predominating over the osteoblast is in effect already. With regards to your T-score, if you multiply it by 10%, that's about the amount of bone mineral density that's been lost. And Z-scores are not used to diagnose you, but they can be a clue for early onset osteoporosis. So if you have osteoporosis, where am I at? I don't want to go over. So how much time have we gone by? About 9 minutes, okay. All right, so what medication should I be taking? So anti-resorptive, so bisphosphonates, those block the ability of the osteoclast to break down the bone. And then you can also take other medications such as Prolia, which is denosumab. That's a medication that builds antibodies to your body's ability to break down bone. And then there are also, those are things that prevent breakdown. There are also medications now on the market, they're newer, that help build new bone, but they have significant side effects. So Forteo. And so those are for patients who cannot take bisphosphonates or those who failed bisphosphonates. This has been in the news because it's used to treat fractures in high-level athletes because it builds new bone. So you may have heard, for example, Terrell Owens, when he was on the 49ers, was being treated for this because he had a fracture within his tibia. It's helped to ramp up their production. But that's an off-label use. The on-label use is through a primary care physician who guides your treatment because you failed bisphosphonates. Calcium, so, excuse me, what are the basic requirements for calcium? If you're 19 to 50, you should have 1,000 milligrams per day. If you're greater than 50, you should have at least 1,200 milligrams per day. Typically, these come in 500 milligram tablets. These are the ones you commonly see in the store. But if you're taking something to inhibit reflux, like a proton pump inhibitor, you have to take citrate, not carbonate. So citrate meaning caltrate, because the calcium won't be absorbed in a non-acidic stomach, which is the case if you're taking a proton pump inhibitor. Vitamin D is also essential. At minimum, you need 800 international units per day, so check your multivitamin to see if that's how much you're getting. Some recommendations are up to 1,000 international units per day. They say you should get sunshine for at least 10 minutes per day. And one other thing to keep in mind is if you have some kind of kidney issue where your kidney is not functioning, the way that you get vitamin D in the counter or over the counter and then in the store, it's inactive. So your kidney has to convert it to the active form to help bone production. So just make sure if you have kidney disease or your kidney doesn't function at an appropriate level, then you need to have the active form being prescribed to you. Okay, weight-bearing exercise is important. It works by the law, it's called Wolff's Law, the law of compression. So if you have compression on the bones, they respond by making new bone. Okay, so that's why this is important, and Ann will get into that. And so compression fractures, just a little bit, because I am a spine surgeon, I'll just give you a little bit of tidbit on this. You can see here on an x-ray, the body has lost its height. Classically, we know if somebody comes in, normally they stand erect and they've started to come in slouched over, our caution or flag should go up and we should be looking or screening for this compression fracture. This is an MRI image of what happens, and you can see the bone is significantly collapsed here. Common symptoms are to have axial back pain. They're locally tender. Like I said, it can happen from these two mechanisms, and it happens most often at where the thoracic spine goes to the lumbar spine because there's a difference in curvature. Treatment, I will always get an MRI to make sure it's not an old fracture. So only if you're tender, it may be a new, so then we'll get an MRI to screen because we can tell if there's blood flowing to that area. Bracing may be indicated mostly for comfort. It's not going to restore your height. Pain medication, you don't want to take things like Aleve or Advil because those will inhibit bone formation. There are nasal sprays that can be used to inhibit the bone breaking down cells. And then one surgical alternative is called kyphoplasty. I'm very selective about who I will offer this to, but not because I don't want certain people to get it, but because there's only certain cases where it will work. So within the first 6 weeks, if you're diagnosed with a compression fracture, the MRI shows that it's an ongoing healing process and you're still healing, then you may be a candidate to receive this cement injection within the bone to harden the bone and stiffen it. And if you're the accurate candidate and you've been screened appropriately, when you get this type of procedure, there's almost an immediate sense of relief. But it's dangerous too because you're putting a hard block of cement into the spine, and imagine how that changes the loading for the bones around it, right? There have been patients who've had this procedure and then develop a compression fracture at the next level. So that's why I say I'm very selective about who I'll choose to undergo this procedure. So moving forward, make sure that you establish guidelines for your bone health. Talk with your primary care physician or your osteoporosis expert. Keep your DEXA results handy because if you ever have a fracture, it's important to know what your level of osteoporosis is. Take your supplements and maintain an active lifestyle. Even 1% increase in your bone density decreases your risk of fracture. Okay. So this was, I was going to talk about this, but I'm just going to skip through it. I think we're short on time. And so if you guys have any back pain questions or vertebral fracture management or practices across the street, feel free to contact or come visit us. And I'll toss it over to Ann here to talk some more.
And it's right. Okay. So yes, once again, welcome, and I'm Ann Pfeifer, physical therapist here at our own El Camino Los Gatos outpatient rehab. Happy to be here with you. I'll follow further with some information. I'm going to be skipping through some slides that the doctor has covered, a little overlap, and really appreciated his detailed input. So I'm going to get right into where does the physical therapist enter into this. And in terms of risk factors that were mentioned, one that's close to my heart as a physical therapist is just when people enter into more of a sedentary lifestyle, that starts to create some problems both in strength and posture and resiliency. Lots of sitting, driving rather than walking, taking elevators rather than stairs. So my job is to encourage you otherwise. And as the doctor mentioned, there can be a gradual change in posture with osteoporosis, and this can be very gradual and insidious. You might not even be aware of pain. It is a silent disease until there's a fracture event or if you have a lot of stress on the elements about the spine. So the physical therapist's job is to help you try to prevent that process as much as possible. And common fracture events, simple things, if you're not using good posture, which we'll discuss, could be just making the bed or carrying groceries, reaching into the trunk with a rounded spine, adding that weight. If you have a fragile spine, this itself can create a spinal fracture. When you know you're at risk, and even for a lot of what I'm talking about here today is really about spine care in general. But in terms of osteoporosis, particular movements to avoid would be anything that flexes the spine, especially under force. So it could be sit-ups or crunches, toe touches, or any kind of bend and twist can be enough to put your spine at risk. So from the physical therapy standpoint, prevention of osteoporosis or slowing the bone loss issue, again, encouraging bone building nutrition, not bone depleting, and appropriate weight bearing and resistive exercise. Yeah. So as we go forward in this talk here, it's about osteoporosis, but also in terms of arthritis of the spine or back issues otherwise. A lot of what we address in physical therapy and what you should address in your life is similar. There's a lot of overlap. The most important thing when I have a client, and it really doesn't matter what their problem is, it's posture, posture, and posture. And then how do you move through the day in a way that minimizes the stress on your joints, so body mechanics. Strength, not just arms and legs, but core strength, which we'll talk about. And balance. Dr. Gidvani mentioned how many of our fracture risks in osteoporosis are because of falls. You fall forward, you land on the wrist. You fall back, land on your buttock, incurring a fracture if your bones are fragile. So balance improvement is hugely important. So we begin with lengthening the body. Whether you're starting with the basics, lying down or standing up, we need to lengthen that body, meaning improve that posture. Starting with sitting. So I might invite you all to make a little adjustment in your sitting posture right now. Get your hips back in your chair, heart high, all right? Use the support of your chair. There's step number one. So if you've learned nothing else today, you've had a little tidbit there. And to improve our posture, again, because, as the doctor mentioned, how the thoracic fractures are more prevalent, leading to a rounded spine, my job is to help you improve and go the other way. So first we have to open the shoulder girdle or the anterior body. We got to open the front and we have to strengthen the back, okay? Starting with a multitude of options. And then we strengthen the muscles of the shoulder girdle and the back, plus strengthening the arms. The picture on the right is weight bearing through the arms, good for bone strength. That's a conservative example, but it's a beginning. And so strength of the arms, very important. And lower body flexibility, along with good posture. So you can imagine if somebody gets rounded, forward bent, we see this all too often. It's not just tightness in the shoulder girdle, but tightness in the hips, the front of the hips. So a big part of my ability to help you, whether it's osteoporosis or spine issues or to begin a balance program, it all requires upright posture. So we have to open up the hips, get good leg and hip flexibility, and then start to strengthen those legs in a variety of ways in weight-bearing positions. So one example is a wall squat. Better yet is squats themselves done appropriately with good mechanics. So it's good weight-bearing and very functional strengthening for you. And then strengthening the spine. So on your belly lifting up, this is strengthening the back extensors, and that has shown to be strongly correlated with fracture prevention in our osteoporosis population. Strength of the back extensors. So it doesn't need to be to that extreme. We have lots of ways. And core strengthening, body mechanics, keeping the back straight as you go from sitting to standing. Again, squat mechanics. Do you do it with a rounded back or a straight back? And never with straight legs. And then balance. So this is one of our beginning balance exercises. And we've had a lot of success with that one. And just fall prevention in your home, decreasing the clutter, well-lit pathways. The doctor mentioned weight-bearing exercise can be brisk walking, dancing, low-impact aerobics, hiking, stair climbing, And at PPI, that's Physical Performance Institute here at El Camino Los Gatos, we do have aquatic therapy plus aquatic exercise on your own at your gym is good, not for osteoporosis so much, but for pain issues of the spine. And we do progress people from the pool to land-based therapy for our spine rehab. So thank you for your time and enjoy the rest of your day. Okay.
So we have time for a few questions.
This question is for Dr. Gidvani. You mentioned about the risk factor for osteoporosis, and one of them is for women who weigh less than 127 pounds. Can you speak to that risk factor on that? Because is that general, I mean, overall statistic, or is it associated with the height as well?
So it's based on studies that have come out of the National Osteoporosis Foundation, and the thought process behind it is that if you are of lesser weight, that your ability to, for example, do weight-bearing exercise, you're not going to have as much rebound compression loading. And I think it's also just sort of looking at a big population and seeing which patients had the diagnosis of osteoporosis. It was those who were of a smaller stature. So it may not necessarily mean because you're lighter weight that you have osteoporosis, but it's just a sort of, if you have that, it may be one risk factor that you're also, you've reached menopause at a younger age and you're a smaller stature, then you may consider talking to your doctor about getting a DEXA scan. But it's not a hard, fast rule.
Hello, I'm talking about the calcium supplements. The doctor who reviewed my scan said I shouldn't take 1,200. I should eat more calcium-rich foods and only take one of the 600.
Sure, yeah.
Concerning the heart or...
Well, so it's all dependent on how you want to obtain that daily amount as a supplementation, right? It may come within your food, it may come from your diet or supplements, but that's the suggested standard. Oftentimes, in patients who are recovering or healing a fracture, we've seen that if they're not on the amount of supplementation that's recommended, they just have a hard time healing. So anytime you fix a fracture with instrumentation, we quote 8 to 12 weeks for healing, and they actually take quite longer, up to 6 months or even up to a year. So that's why I say it's a discussion between yourself and your primary care physician, sort of, what's the best way to go about it for your particular situation. It may be based on laboratory values that they've done, but that's the basic requirement that's listed.
I have a question regarding the bisphosphonates. What are your thoughts on how long someone should stay on it because of the risk of femur fractures that's been in the literature?
So time-wise, I didn't get a chance to delve into that, but it's a very good question. It's been of recent interest, I'd say within the last 5 years. People have been on bisphosphonates for an extended period of time. There are significant risk factors. Some of them are more obvious than others, such as osteonecrosis of the jaw, or there was a picture up there of the jaw. It said your dental health when using bisphosphonates, because you can get death of the bone within the jaw. So that's a very significant risk factor. But with regards to femur fractures, what we've now found is that you are at risk if you take it for a long period of time of developing what's called a subtrochanteric femur fracture. So if you think of the ball of the femur, it's attached to the shaft by the neck. Even below that, there's two prominences called the trochanters, and then the subtrochanteric region is below that. So if you've been on it for a long time, you may want to talk to your primary care physician about getting a femur x-ray. And what is typical, if you're at risk for that fracture, is you'll see thickening of the bone in the subtrochanteric region. And those people have been found to be at increased risk, so then it may be time to come off the bisphosphonates and change your medications to a different form of supplementation. To rely more heavily on supplementation and come off the bisphosphonates.
So please help me in thanking Dr. Gidvani and Ann Pfeifer.